Welcome to the Deep Dive. This is your weekly neurology deep dive. Today, we're digging into excerpts from a recent paper all about repeat expansion disorders in neurology. And just a quick but really important note before we start. This is purely for educational purposes. There's no commercial goal here. It's really just a summary of the source material. And we absolutely recommend reading the full paper for all the details and the complete context. So our goal today is to explore these complex repeat expansion disorders, understand their, well, significant impact on neurology, and pull out the practical points that you need for your clinical practice. These conditions really do represent a substantial burden of neurological disease. Let's get into it.
Okay, so let's start with the basics. What exactly are we talking about? We begin with short tandem repeats. These are essentially repetitive DNA sequences, usually up to about 6 base pairs long, repeated one after another. They're actually a normal part of our genome.
Right? These little repeating DNA blocks naturally occurring.
Precisely. Now, a repeat expansion disorder arises when one specific short tandem repeat sequence gets amplified, repeated many times more than usual. It goes beyond what we call a pathogenic threshold. And that number, that threshold, it varies quite a bit depending on the disorder and the specific location in the gene.
And when you look at neurogenetic disorders overall, the scale is just immense. The paper notes that something like half of the roughly 8,000 known rare genetic diseases have some neurological aspect. Individually rare, yes, but collectively, they're common. The estimated cumulative lifetime risk is around 1 in 17 people. That's significant.
It is, and that leads directly to a major diagnostic challenge. Even with powerful tools like whole genome sequencing, the source suggests up to 80%, 80% of patients with a suspected genetic neurological condition remain undiagnosed. A big part of that problem, that bottleneck, is the difficulty in reliably detecting certain types of genetic changes, particularly structural variations like these repeat expansions. Standard methods can miss them.
Which is exactly why these repeat expansion disorders are so critical for neurologists to understand. We're talking about around 60 described disorders currently, and the vast majority are tied to neurological or neurodevelopmental diseases. They manifest in such a broad range of ways across so many different phenotypes that while most neurologists are definitely going to encounter patients with these conditions.
Absolutely, and we're finding they're behind a significant proportion of certain common neurological diseases. Take the C9orf72 hexanucleotide repeat expansion. It's now recognized as the most common genetic culprit for both amyotrophic lateral sclerosis, ALS, and frontotemporal dementia, FTD. And importantly, it's found in both familial cases and cases that appear sporadic.
Or the RFC1 pentanucleotide repeat expansion, now known as a common cause of Canvas syndrome, that combination of cerebellar ataxia, neuropathy, and vestibular aplexia.
Yes, and another key one, especially recently, is the FGF14GAA repeat expansion. This is linked to spinocerebellar ataxia type 27B. Its discovery has explained a really high proportion of previously mysterious lead-onset ataxia cases. Identifying this has been, well, quite impactful for diagnosis.
So the clinical picture is incredibly varied. We see things like epilepsy, for instance, familial adult myoclonic epilepsies. Then there's ataxia, covering the spinocerebellar ataxias, Canvas, Friedreich's ataxia, cognitive impairment, like in C9orf72 related FTD.
Movement disorders, too. Huntington's disease is the classic example, but also X-linked dystonia Parkinsonism. Learning difficulties, like in Fragile X syndrome, and neuromuscular conditions myotonic dystrophy types 1 and 2, oculopharyngeal muscular dystrophy. Often patients present with a mix of these.
Looking at the molecular level helps explain some of this diversity, right? What factors influence whether an expansion causes disease?
Several key things. The overall size of the expanded repeat is crucial. Also, where it is in the gene, is it in an untranslated region, an intron, an exon? The specific sequence of the repeat unit, the motif, matters enormously. And the inheritance pattern, is it recessive, needing 2 copies, or dominant, needing only 1? Diagnostic reports usually detail these first 4 points: size, location, motif, and inheritance. Things like stability across generations or different cell types are also factors, though less commonly reported up front.
And you mentioned location affecting size. Non-coding expansions, like in untranslated regions or introns, they tend to need to be much larger to cause problems.
That's generally true. Think of Fragile X syndrome that involves over 200 CGG repeats in the 5' untranslated region of the FMR1 gene. Hundreds, sometimes thousands. Compare that to exonic expansions like the CAG repeat in ATXN1 for spinocerebellar ataxia type 1. There, the pathogenic range might start around, say, 36 to 39 repeats, much smaller.
And the motif itself is critical. The Canvas example is striking. AGG repeats in RFC1 are pathogenic, but a very similar AG sequence is benign.
Exactly. And some expansions aren't even simple repetitions of what's in the reference genome. They're insertions of new repeat sequences. The size of the repeating unit also plays a role. Trinucleotide repeats, like CAG or CGG, are the most common culprits, followed by hexanucleotides, like the C9 or 72 repeat. Interestingly, trinucleotides seem to mutate, or expand, more readily, maybe 4 to 7 times more often than tetranucleotides.
Okay, so for clinicians listening, a big red flag or clue should be this clinical heterogeneity, the variability in presentation.
Definitely. That variability can manifest in a few ways. Often there's a correlation between the size of the repeat and the severity or age of onset. Larger expansions frequently mean earlier onset and more severe disease. Think of congenital myotonic dystrophy type 1 versus the adult form. But it's not a perfect predictor. Penetrance, whether someone with the expansion actually shows symptoms, and other genetic or environmental factors complicate things. You can't really counsel based only on repeat size.
And sometimes different ranges of repeat sizes cause different syndromes altogether from the same gene.
Precisely. FMR1 is the classic example again. Over 200 CGG repeats cause Fragile X syndrome. But an intermediate number, say 55 to 200, repeats the premutation range, is linked to Fragile X-associated tremor ataxia syndrome, FXTS, or primary ovarian insufficiency.
Right, and ATXN2 as well. Intermediate repeats increase ALS risk, while the full expansion causes spinocerebellar ataxia type 2.
Exactly. So getting an accurate estimate of the repeat size is really important because it can point towards different conditions or risks.
And sometimes the variability happens even within the pathogenic range, irrespective of the exact size, like with C9R72.
That's right. Someone with a C9orf72 expansion might develop FTD, someone else might develop ALS, and another person might develop both. It's not strictly tied to, say, having 500 repeats versus 1,000 repeats once you're in that expanded range.
This variability across generations points to another key concept: anticipation.
Yes, anticipation is a hallmark. It refers to the tendency for the repeat expansion to become larger, more unstable, when it's passed down to the next generation. This often leads to the disease appearing at an earlier age or being more severe in children compared to their parents. It's often more pronounced when inherited from the father due to instability during sperm production.
Except for myotonic dystrophy type 1, where it's maternal transmission linked to the severe congenital form.
That's the notable exception, yes. But seeing that pattern worsening disease across generations is a very strong clue for a repeat expansion disorder.
But, and this is crucial for practice, the absence of a family history doesn't rule it out, does it?
Absolutely not. Because of that instability between generations, and also because of reduced penetrance, meaning some people with the expansion might have mild symptoms or none at all, especially in late onset disorders like SCA27B, the person you're seeing might be the first in their family diagnosed.
Population background can sometimes provide a subtle hint, too, due to founder effects.
It can. Certain repeat expansions are known to be more common in specific ancestral groups. For example, spinocerebellar ataxia type 3 is more prevalent in people of Portuguese descent. The C9orf72 expansion is more common in Europeans. X-linked dystonia Parkinsonism mainly affects Filipino men. Huntington's disease-like 2 in those with African ancestry. Denatural pallid delusion atrophy in Japanese populations.
Neuronal intranuclear inclusion disease also shows population differences.
Right. Different underlying genes seem more common in East Asian versus European populations for that condition. So being aware of ancestry might sometimes slightly raise or lower your suspicion for a specific expansion.
And pathologically, some of these different disorders can look similar under the microscope, those intranuclear inclusions.
Yes, there can be converging pathology. For instance, those ubiquitinated eosinophilic intranuclear inclusions you mentioned are found in FXTS, but also in neuronal intranuclear inclusion disease and SCA4. And sometimes, as in NOTCH2-NLC-related neuronal intranuclear inclusion disease, these characteristic inclusions can even be detected in a skin biopsy, which is quite remarkable and diagnostically useful.
So given all this complexity, the variable presentation, the tricky genetics, how do we actually go about testing for these disorders in the clinic now?
Well, the traditional methods involve targeted polymerase chain reaction, PCR-based tests. Sometimes these needed to be combined with southern blotting, especially for very large expansions. But this was often slow. You could only test one or a few genes at a time, and if your initial suspicion was wrong, it meant going back and testing sequentially. Low yield, time-consuming.
But technology has moved on quite a bit, especially with whole genome sequencing.
It really has. The big advance has been the development of bioinformatic tools, like Expansion Hunter, that can analyze the raw data from short-read whole genome sequencing. These tools can estimate the size of known repeat expansions across many different genes simultaneously. The paper cites a study from the 100,000 Genomes Project showing really high accuracy for 13 common loci, 99.1% sensitivity, 100% specificity.
So you get a broad screen from one test. That's a big shift. Does it catch everything?
It's a major step forward, allowing simultaneous checks for many expansions, including non-coding ones often missed by exome sequencing. But there's a caveat. These tools might struggle with or underestimate extremely large repeats sometimes. They're very good, but not perfect yet for every situation.
Okay, so practically, how does testing work now? Let's use the example pathway from the NHS Genomic Medicine Service in England mentioned in the paper.
Right. The approach is becoming more integrated. If you have a very strong clinical suspicion for one specific common repeat expansion disorder and a reliable standalone PCR test exists for it, you might still request that directly. And crucially, some disorders, like myotonic dystrophy type 2 or oculopharyngeal muscular dystrophy, currently only have validated standalone PCR tests available routinely. They aren't yet reliably detected via the standard whole genome bioinformatics pipelines in that system.
So you have to know which ones need that specific request.
Exactly. But if your suspicion isn't that narrow, or if a standalone test isn't readily available or validated for the gene you suspect, the pathway increasingly involves whole genome sequencing. Your clinical rationale, the patient's phenotype, determines which virtual panel is applied to the whole genome data. This panel tells the bioinformaticians which specific repeat expansion loci to screen using tools like Expansion Hunter.
So for an adult with unexplained ataxia, you'd request the R54 panel, hereditary ataxia with onset in adulthood.
Precisely. And that panel definition instructs the lab to specifically look for expansions in genes, causing SCA1, 2, 3, 6, 7, 10, 12, 17, Friedreich's ataxia, DRPLA, Unverricht-Lundborg disease, and FXTAS within that patient's whole genome data.
And if the bioinformatics tool flags a potential pathogenic expansion in one of those genes?
Then a confirmatory test, usually a specific PCR-based method, is performed to validate the finding and get a more precise size measurement.
Okay, that makes sense. Screen broadly with bioinformatics on the genome, then confirm specifics with PCR. But the key takeaway is knowing what's on the panel versus what needs a separate order.
Absolutely critical. For instance, the RFC1 expansion for Canvas often needs to be requested as an additional companion PCR test alongside the R54 ataxia panel or the R78 neuropathy panel in that system, as it wasn't initially included in the routine bioinformatics screen. Things change, panels get updated, so the best advice is always to check the latest test directory information or consult with your local genomic laboratory hub.
And looking further ahead, what's next in testing technology?
Well, there's ongoing research into tools like Expansion Hunter de novo, which aim to detect novel repeat expansions, ones we don't even know about yet, directly from genome data. That's exciting for discovery. And long-read sequencing technologies definitely hold promise. Because they read much longer stretches of DNA, they're inherently better at accurately spanning and sizing those really long, tricky repeat regions. They aren't routine for clinical diagnostics just yet, but they are coming.
The paper also had some brief case examples that really highlight these points. Case 1, a 10-year-old child with intellectual disability and complex neurological issues, but healthy parents.
Yes, and whole genome sequencing analysis using Expansion Hunter found a huge 99 CAG repeat expansion in the ATXN2 gene. This diagnosed a very early onset form of spinocerebellar ataxia type 2, quite different from the usual adult presentation and wouldn't have been suspected without that broad screen.
Case 2 showed anticipation clearly. A young child under 5 with ataxia and developmental delay. Whole genome sequencing found a large ATXN7 expansion, 120 CAG repeats, diagnosing early onset SCA7.
And the striking part was the father. He only developed symptoms 2 years after his child's diagnosis. He was then tested and found to have the same expansion, but likely smaller or with later onset. It perfectly shows how the child's earlier severe presentation can occur before the parent is known to be affected.
And Case 3 demonstrated the ongoing need for targeted testing based on clinical suspicion. A man in his 60s with tremor, cerebellar signs, and classic MRI findings suggestive of FXTS. His grandson also had learning difficulties. Here, despite the availability of broad genome screening, the specific clinical picture pointed strongly to FMR1.
Right, so direct PCR testing for the FMR1 CVG repeat was done, confirming a premutation in the grandfather, explaining his FXTS, and a full expansion in the grandson, causing Fragile X syndrome.
So these cases really drive home that instability means family history can be misleading, that whole genome screening is powerful for complex cases, but also that clinical variability is the norm, even within families.
Exactly, those are the core messages.
Okay, so wrapping up. Repeat expansion disorders are, well, a really significant group of neurological conditions. They're often clinically heterogeneous, which can make diagnosis tricky. Recognizing key features like anticipation, even subtle shifts in severity or onset across generations, and the sheer variability of presentations is vital.
And the advances in genetic testing are making a huge difference. That combination of whole genome sequencing with sophisticated bioinformatic analysis backed up by targeted PCR is really boosting diagnostic yield. But it requires clinicians to be aware of the current testing strategies and limitations.
And looking forward, the fact that new repeat expansion disorders are still being identified, often in previously overlooked parts of the genome, is really stimulating. Plus, the growing understanding of shared disease mechanisms across different repeat disorders offers hope for developing future therapies. Understanding this group of diseases collectively is just increasingly important for all neurologists.
Well said. And just one final reminder, for all the nuances and complete data, do consult the original publication.
Absolutely. It's a field that's certainly not standing still.
Yeah.